Good morning, PT on Ice podcast. My name is Dr. Jessica Gingrich, and I am on faculty with the PPP crew. I am fresh off a plane at 2 o'clock this morning, coming from Oklahoma City, where Christina and I had the live course, and it was such a wonderful time. Our live course consists of learning the internal exam and bridging that with exercise. And so day two, we're in the gym where there are barbells, dumbbells, kettlebells, rigs, and we have a fabulous time learning movements, perfecting movements, and then modifying for the pregnant and postpartum athlete. So if that is on your list, the next live course is in Grand Rapids, Michigan with Alexis on May 6th and 7th. So go ahead and head over to ptoниce.com to sign up for that. So today we are going to talk about diastasis recti and its association with low back pain. So this is a 2023 systematic review. And I think this is going to be a fun article to talk about because we have so much literature coming out regarding diastasis. It's also a hot topic in the pelvic space where we have a lot of clinicians that feel either really comfortable or they're not so sure treating this population. What we now know is over half of the population, pregnant or not, male or female, has a diastasis. We also know that it's not clearly defined, and we've been trying to do that for so long. But the definition in regards to width, depth, and even quality of tissue tension underneath, we just don't have a clear definition. We may have a long way to go continuing to study this, but we may not find a clear answer. I think that oftentimes we try to make things black and white when in fact they're just not. So let's dive into this. So this systematic review investigated the relationship between diastasis recti and low back pain. This was in all populations, not specifically to pregnant or postpartum. The researchers hypothesized that there would be a positive correlation. In this review, they specifically defined diastasis recti as a separation of the rectus abdominis from the linea alba, which is a common condition in pregnancy, postpartum, women, and in the obese population. Before we continue, I want to just touch on this definition quickly. This implies that the rectus abdominis is coming away from the connective tissue that is the linea alba. This is a really fearful messaging, can cause fear of movement. And I'm wondering if that's how we should be defining diastasis to our clients. So the methods of this article, they used search engines like PubMed, Cochrane, Imbus, and they used key phrases, low back pain and diastasis recti, or rectus abdominis, or abdominal wall, or paraspinal musculature. They excluded editorials, reviews, letters to the editor, cadaver studies, animal studies, and studies with incomplete records. The results of this process yielded 13 non-randomized studies. Of the studies included, 3 were prospective cohorts, meaning they looked out in the future. 5 retrospective cohorts, meaning they looked back. And 5 observational cross-sectional, which is a type of observational study that analyzes data from a population at a specific point in time. They rated these studies 8 or less was considered poor quality, between 9 and 14 moderate quality, and 15 to 16 was good quality. 4 out of the 13 studies found no association between diastasis recti and low back pain. However, these 4 out of the 13 were moderate studies. The rest of the studies were poor or either found no association or a positive association. So they found no correlation, or it was positive, but the studies were poor. Amongst the studies included DRA was not clearly defined, and most studies use the "do you have low back pain, yes or no" question as a screening for low back pain. 4 used the visual analyze scale, and only 1 even defined what low back pain was. So the first and most important thing is the strength of this, right? The strength of the systematic review is only going to be as strong as the studies that are used in it. It is directly related to the quality of the studies. In this regard, only 3 prospective studies were included. Since most of the studies were retrospective or cross-sectional in design, that may limit the strength of the conclusions from this article or this review. Another limitation of this study is related to the definition of diastasis recti and the poor assessment of low back pain. There may also be a selection bias based off of the definition of diastasis. Also, this article did not define the inclusion criteria. So what they found was the conclusion was that most of the studies did not find an association with diastasis and low back pain. So I wanted to bring up some discussion points. If you are in this space, whether it's the pelvic space or just orthopedic space, and you are seeing diastasis recti and low back pain, how can we communicate this? How can we bring this in real time to our clients and keep it from becoming this very black and white picture? So low back pain was not clearly defined, meaning this could be segments of the lumbar spine which weren't assessed. This could also be posterior pelvic girdle pain, which in and of itself was not clearly defined in the literature with regards to successful intervention. Having a team of researchers that know how to assess, to rule in or rule out specific regions associated with pain patterns, pain referral, and comparing these individuals with relaxin levels. We hear a lot about relaxin levels as well within pregnancy. Something important to note is that we see low back pain in all populations, specifically in the pregnant and postpartum population. They get told that their pain is related to something that happens to their bodies during pregnancy. This could be diastasis, weight gain, or weight shift, maybe even relaxin, etc. However, we see diastasis in all populations with and without low back pain. So, bringing this back to a clinical side of things, instead of blaming this problem on something outside of their control, and right now, maybe that diastasis recti may be a little bit outside of their control based on the education that the general population has around diastasis. When they have that diastasis, they are oftentimes told to stop doing crunches, stop doing planks, stop doing really any core altogether, which now is deconditioning their core and making things in life a little bit harder. And I don't want to say that it's making their diastasis worse because we don't know that, but it certainly is deconditioning them and making them weaker. We want to decrease fear as much as possible so this population continues to exercise. I think we need to stay in our lane and do what we're good at. Find the root cause. Where's their pain coming from? Decrease irritability, and then build strength and resilience. So taking these articles that were the literature that's coming out into our world is reading it, understanding what they're trying to say, and recognize that this study may apply to your patients, but there's probably going to be some gray area. And the best thing that we can do for them is stay positive, use positive language, find the root cause, decrease irritability, build strength and resilience. All right, with that, I hope you guys have a great Monday. We will see you next time for the PPP next Monday.